Hi, everybody. I'm François. I'm a physician based in Johannesburg in South Africa. And thank you for joining us today. I'm delighted to be able to talk on a new drug. And so it's really great to get excited about new drugs and new antiretrovirals again. We're going to be talking about Islatravir today. And I'm going to try and cite it in an area I'm more familiar with, which is antiretrovirals in the area of low and middle income countries. So these are my disclosures, the most important one being that we are actually doing work for Merck, who's developing Islatravir within my own unit. Importantly, one of the organizations, whenever you're looking at wanting to know about new drugs, is HIV iBase. They do the most amazing work, and this report they issue every year called the HIV Pipeline looks at all the updates in terms of antiretrovirals, in terms of TB drugs, in terms of diagnostics, hepatitis C. So whenever you really want to hear about what's happening in the world of new drug development, go and look at this group. They're a group of amazing activists based in London and New York who do this update, and the entire world of HIV drug development relies on this report coming out. And certainly where I got my information on Islatravir. So we've had some great leaps forward in the last little while that we're looking for, and we're looking forward to some great leaps forward now in terms of antiretroviral development. And the two major ones which are coming, and the first one is in the area of these long-acting drugs that Islatravir are part of. And the reason we're looking forward is that suddenly the bar is really high. The new oral integrase inhibitors, particularly dolutegravir and bictegravir, have set the bar really, really high. And the combination antiretrovirals they come with are phenomenal. They're almost unbreakable. The resistance barrier until now is almost, in first line, it's almost unknown to fail these drugs. And they're also incredibly well tolerated compared to the efavirenz-based regimens and all the previous iterations we've had. The tenofovir and taf-based combinations of bictegravir and dolutegravir are almost universally well tolerated. The side effect profile is, as I say here, phenomenal. And I've put you in little letters so far, but with every passing month, we know that these drugs are tolerated for years and years. And the database on these classes of drugs is just getting bigger and bigger and bigger. This is not D4T. This is not even, these are not Aluvia. These are not, the surprises are not coming on in terms of side effects or breakthrough resistance. They're also very limited drug-drug interactions. They're really just with, the major ones are with metformin and with rifampicin. And certainly in my area of the world, hormonal contraception, which is a major headache with efavirenz, it's not a feature of either one of these new generation of integrase inhibitors. And also amazingly is there are multiple fixed-dose combinations made by multiple generics. But the big leaps forward are the long-acting, the rise of these long-actings. And I think that we're all suddenly getting familiar with these new innovative delivery systems. Everyone's suddenly talking about these as well as amazing things like the microneedle administration patches and things. And there's a whole industry that's coming together around drug administration, not just for antiretrovirals, but for whole other exciting areas. The next thing is that we're seeing the aligning again of prevention and treatment. Now, in the old dark days of antiretroviral treatment, we had AZT and Aluvia, and in combination with lamivudine being used for PEP and for treatment. And that stopped any development of the two because these drugs just had such ghastly side effects in terms of, certainly in the case of AZT and Aluvia, that there was no way that they were going to be used for routine prevention other than for PEP. And for about 10 to 15 years, until the arrival of tenofovir-based PrEP, there was no way that these drugs were going to be used for prevention. But now we've suddenly got the rise of tenofovir, diazoxyl fumarate, and TAF. And now all these wonderful new long-actings that are being dangled in front of us as both orals and injectables and even implantables that mean that we can use these drugs as both treatment and as prevention. But what about this new drug Islatravir, and why are we so excited about it? Now, firstly, it's what we call, and I still have a great deal of difficulty trying to remember how to say this, a nucleoside reverse transcriptase translocation inhibitor. And it's probably better to remember it simply as an NRTI+, I guess is the way I'm trying to get my head around it. It's derived from a soy sauce flavoring, which is maybe not something the Merck marketing people are delighted at seeing me saying, but that's where it comes from. Merck bought it in 2012, and one of my very grumpy pulmonology professors rages at me and says that the HIV seems to have a whole cottage industry in having multiple names for its drugs. And Islatravir has, to his horror, this multiple names. And you may see the particular term EFDA and ISL is the common contraction that we seem to be using at the moment, but it used to be called MK8591. Now, just a quick aside, when I was researching this lecture, and for those of you with like slight nerd built to you, there's that this is one of the few manufacturing stories around antiretrovirals which actually made its way into science. And this Islatravir is entirely made by enzymes. And traditionally when we make antiretrovirals, we take chemicals and we kind of have multiple synthetic pathways, and at every single pathway, the chemical either gets sort of synthesized down, and there's waste, and there's all sorts of environmental damage, and that adds to cost, and and the pharmaceutical ingredients that have to be sourced adds to the complexity of it all. Islatravir, though, comes with a term I'd never heard of before, called biocatalysis, and it's amazing reading the articles around this sort of biochemical awe at the whole process of it. Merck actually invested significant resources into the processes to make this. And by using only enzymatic processes, there actually is no waste. And appears this is quite a revolutionary mechanism, judging by its way above my pay grade. But this might be a new way to manufacture certain kinds of drugs, including Islatravir. And you can see some of these breathless comments from some of the basic scientists here at the bottom. And then I found, and you can see the science article up at the top here. And this, again, I think the manufacturers, particularly in the COVID era and these anti-vaxxers running around, probably don't want to hear the term unnatural nucleoside. But this website, Drug Hunter, you can see this kind of these breathless quotes in the bottom here of these biochemical nerds sitting around analyzing how Islatravir was made. And it really does seem as if that large volumes of this can be made very, very efficiently going forward, which has huge implications for people like me who are very interested in, can we make these drugs cheaply and more efficiently going forward for low-income markets. So yeah, just look at this stuff. It's really, really interesting. So how does it work? And this stuff always makes my brain sore as a clinician. This is really the basic science stuff. As I said, it binds very, very firmly, far more firmly than the other NRTIs, to the reverse transcriptase. And this, I've referenced it here, this website is a really good place to look at how this mechanism works. And it does this classic thing where it prevents the elongation of the DNA primer and causes the classic chain break that you see with the other NRTIs. But then it overachieves, and if elongation does occur, which is not clear to me actually that if it does occur, it causes what's called a delayed chain termination. And then, just in case the drug hasn't done enough, it then has to slow metabolism from its phosphorylated form back to classic Islatravir, and then diffuses out of the cell back into another cell to do its wicked work back within other cells. So why are we excited, and why even people like the Clinton Foundation, who focus very much on cost reductions and on volume controls and things like that, why are they so excited about this molecule? Well, firstly, it's extremely potent. It drops, even as monotherapy, it drops the viral load dramatically. And it doesn't just work against HIV-1, it works against HIV-2, it works against multi-drug resistant HIV-1. It's got this phenomenally long half-life that allows you to, even with oral forms, to dose it monthly. And it's kind of got this resistance barrier. We're almost getting spoiled around. It's almost impossible to break. We're starting to see this with dolutegravir and bictegravir. We're seeing it with lenacapavir. We're starting to get used to this idea that, we don't expect these drugs to develop resistance. And this is exactly what we're seeing with Islatravir, is that this quote I took out from one of the papers, no single amino acid substitution was shown to significantly decrease its potency. And even though classic mutations like M184V mutations do decrease its potency somewhat, it's still highly, highly potent. The dose is remarkably low at a daily dose of 0.75 milligrams. I mean, this is like, that's like a sprinkle you put on top of your cupcake. At weekly dose of 10 milligrams and the kind of monthly dose of that you see with dolutegravir, you normally dose daily at the oral. And when they combine it with doravirine, one of the drug studies I'll be talking about in a moment, they talk about how they have to lightly spray it on the doravirine because the dose is so small. And because of this, they can also start using it in implantable forms. I'll be talking about that in a moment as well. And again, they're not seeing drug interactions with hormonal contraception. Again, very good news for people working in my part of the world. It's also, and this is obviously preliminary data, they haven't used this in tens of thousands of people yet, but what data we have is that at the doses that are showing clinical efficacy or virological efficacy, it's just very mild forms of headache and diarrhea, which appear to be very mild and tend to resolve very quickly. So preliminary safety data, very encouraging. And this just shows you these very, very long half-lives, which are actually a bit of a headache for the company because they're battling to find other companies they're battling to find other partner drugs which have similar long half-lives. And this just shows you some of the, this is Jay Hrobler, who's at Merck and who's been involved in developing the drugs, but you can see just some of the dosing levels they've been playing with up there on the left. And the timing of the doses. And then on the right, you can see how they've compared islatravir with the other classic NRTIs in terms of its inhibitory quotients. All of this data is sort of trickling along and sort of towards the end of the last decade. So in terms of its treatment trajectories, the first reports, actually Jay was one of the ones who put it out there, started coming out towards 2016. Merck tends to be quite slow in terms of developing its antiretrovirals versus, say, the likes of Gilead. But now firmly into phase 2 and 3, and I think Merck have realized they might have a potential blockbuster on their hands. And as I said, that's one of the problems is they've had is finding a potential partner drug that has the similar long half-life. Hence, the alliance recently announced earlier this year with Gilead, I think with an eye on partnering with lenacapavir and putting the two drugs together, potentially with an eye on the kind of monthly dosing of the two drugs, and potentially also fusing it into potential other forms of implantable, injectable, and potentially long-acting formulations of one form or another. And you can read about the scientific pairing just by Googling it and finding out what's in. And then they're looking at the various combinations. The initial pairing was with 3TC and doravirine, another Merck in the NRTI. The 3TC was paradoxically dropped recently in terms of the study. They were seeing blips, which doesn't make complete sense to me, but it doesn't matter because doravirine islatravir by itself seems to be working pretty well in phase 3 studies, and that's proceeding. Merck also has another NRTI, which can be dosed weekly, and they've got this is a weekly dosing oral drug, which is really, really novel. Appears to have a very similar, it looks very similar to doravirine in terms of its resistance barrier. Neither one of them seem to have any hormonal contraception side effects. So we have what looks like a very highly potent in terms of its resistance barrier, well-tolerated weekly tablet on the horizon if it gets through the phase 2 and then through successful phase 3 studies. And Merck's going through the classic sort of studies. They've got all the usual naive, looking at patients who are experienced, multi-drug resistant patients, switch studies, and then they've got quite a rich pipeline in terms of tackling the pediatric populations as well. So fairly classic development pipeline here. As I said, just the complexity being the difficulty of having a partner drug in all of this. Also interestingly, quite an active pre-exposure prophylaxis arm, and I think that cabotegravir has electrified the PrEP field. And the idea that injectables can outperform orals in terms of the cabotegravir studies have made us all think that perhaps this is the way to go for PrEP going forward. They've got this oral 60 milligram monthly dose, which is again, tiny, tiny dose, which would be, if the side effect profile is what we're seeing, would be incredible. It's But also, remember, Merck has a long history of contraception, particularly in the area of implantables and injectables, and taking this expertise and applying it to Islatravir is what they're busy doing. And so there's a lot of interest in starting to use this. And can you imagine an annual implantable that could be administered to young women as a PrEP intervention, or to any high-risk population? I think that we're seeing the potential here for a complete, massive leap forward in the PrEP field. And there's also been interest in applying this technology to the vaginal ring. And I think we're seeing the depivarin ring slowly making its way into the market at the moment. But starting to apply this technology there as well, using all the lessons we've learned from the previous ring studies, and hopefully finding this is a more potent version compared to depivarin. So the potential here is large for Islatravir. We have weekly, monthly treatment options. We've got the PrEP monthly or annual options. If the generic licensing occurs, and Merck has indicated that they'd be open to this, and there are discussions happening, the milligram dosage as well as the manufacturing options, talking to the generic companies, there is the potential here for major cost reductions to occur. So for people like me and people in my area of the world where cost is a major issue, that is pretty exciting. There are, however, complexities, and I think that we need to be conscious of this, thinking about this. New drugs don't immediately mean that that all manner of evils get solved in the world, and simply being cheap does not mean that solves all the things that we need to be solved. And there's a lot of hard work that needs to be done, and particularly around these drugs still are largely tested in men, and we need to know what happens in pregnancy. We would need to do the hard work of starting to do that, and thankfully that is starting to be done. My own unit is starting to use these drugs in women. We need to know about drug-drug interactions, some of the more common ones, and that work is starting to go forward. So far, the work is quite reassuring. And then we need to see what safety is like in the populations where they get used, so that we don't repeat some of the mistakes we've seen when drugs get rolled out to tens of millions of people, and then suddenly we have to pick up the pieces later. So that hard work is going to take a few years. So if we are going to go down this route of exploring this drug and any new drug, this is what we're going to let ourselves in for. And we've got to ask ourselves, is a weekly tablet a step forward for adherence? And I think people from the antidepressant space and from the contraception world, where they've been using these strategies, can teach us a lot. And I think we need to start pulling them in to start asking is, how do we get adherence? Is taking one tablet on a Saturday better than taking a tablet every day? I don't know. I'm so used to the step forward from one tablet a day from the old days when we used to take tablets 3 times a day. That was as good as it got. So this, we may need some teaching around, and what happens when we start taking a tablet monthly. There's a lot to learn here from a complexity perspective. And is it worth it? To the dolutegravir-based regimens we have across the low and middle income countries are working so well. Is it all worth it? We are going to, unless we add TAF or we add tenofovir, we're going to use the hepatitis B cover. Are we able to deal with that? And do we have alternative strategies to deal with it? And will we see these cost reductions? At the moment, the tenofovir 3TC dolutegravir regimens cost somewhere between $60 and $70 a year. Will it be worth going down this road? And what sort of cost reductions are we going to see at scale if we do go down an Islatravir with a paired treatment option? And how does it occur? PrEP's probably going to be significantly cheaper, but all of those things need to be factored in, and the economists need to get cracking with the work. So in conclusion, this is an exciting time. It's clear that injectables, implantables, long-acting orals are all part of the future. And we've got a couple of really good candidates. Which ones are going to be the best and which ones are going to be the ones we're going to use in the future are not entirely clear to me. Islatravir is certainly one of the exciting ones that are there. And you're going to hear a lot about the others in this session and in others at the conference. So yeah, we'll see which ones pan out. There is the potential for these long actings and in Islatravir for both treatment and for pre-exposure prophylaxis. They offer possibly significant more convenience. This might benefit adherence. There's also the possibility of less cost, and that might be both in terms of the manufacturing processes, but also the non-sexy stuff like packaging. You just might have much less packaging if you're taking a tablet once a month than you would be when you're taking these tubs once a day. So the cost, obviously, in my area of the world is a big deal. And it's going to be a long road ahead, and there's lots of work for us to do in terms of making sure that women can take these drugs safely, that pregnancy can be safe, that there's safety in local populations, that we don't get any unpleasant surprises if we use it in tens of millions of people, that doesn't just get trialed in gay white men in North America, that we do it in the populations that are going to receive this. That we work with which partner drugs are going to be there, and that the licensing debates happen as quickly as, and processes and negotiations happen with the generic companies as quickly and as efficiently as humanly possible. I think there's a difficult discussion and an important one to be happening, an interesting one around adherence. Like, how do we deal with the monthly and the weekly and adherence issues? How do we set up injection sites, implant sites? Where do we do the implants? And those things need to be thought about, and we may need to step outside of our narrow little HIV field and go with the contraception and, as I said, the antidepressants and other fields, and people who actually have experience in this area and tap their expertise and their brains for what happens. But it's an exciting time, and I think that, as I said, I think with the daily oral, this is pretty good. It might be as good as we get, the sort of dolutegravir, bictegravir combination. But starting to think beyond this, and these long actings might be the next frontier that we need to start occupying our time with. I'd just like to thank all the organizers and my team who helped make all this happen.